Is it recording? Okay, I think it's recording. Okay, so this is the audio video for screening for differential diagnosis. Again, your overall goal is to identify a complaint not related to the chief complaint for being in physical therapy, like dizziness. By the time you get to the end of the flow chart, if you can move that, oh, you can move it, you have collected a lot of data. You use this in conjunction with all of the other info you are collecting. Let's go back. So first we're going to do medical history review, which means you're going to review the chart and do a patient interview. You're going to ask about complaints and functional limitations. How are they performing at home? What kind of complaints they have, pain, etc. And then you're going to do a review of systems, general health, constitutional complaints related to other systems like your cardiovascular, pulmonary, gastrointestinal, genital, urinary, psychological, endocrine, nervous system, integumentary. And then after that, you're going to do your first hands-on assessment with the systems review. The cardiopulmonary, the integumentary, the musculoskeletal, the neuromuscular, and then the communication, learning style, and effect and cognition. And then you're going to do your special tests and measures. Medical history components, intake and interview combined. So you're going to get the demographics, social history, employment work, growth and development, living environment, general health status, social and health habits, past and current, family history, medical and surgical history. And then you're going to ask about their current condition and their chief complaints. How do we expand upon this? Functional status and activity level, medications, and other clinical tests. Review of systems. The review of systems is a checklist of common symptoms representative of diseases for a particular body system. The objective is to identify potential health problems, not necessarily associated with the physical therapy chief complaint. And when do we do this? It's dependent on the patient's health history and location and pattern of pain. We must determine when a red flag is really a red flag. Major body systems to screen that may require medical referral. Cardiovascular pulmonary systems, eyes, ears, nose, and throat, gastrointestinal system, genitourinary reproductive systems, hematologic lymphatic systems, integumentary systems, neurologic musculoskeletal systems, and the endocrine system. Screening questions. Systems review. Guide to the systems review. Ways of reporting results in a brief exam or screening. And this is the first hands-on part of the exam, reported as impaired or not impaired. The document specifies as document specifics as appropriate. So the categories for the systems review. You got cardiovascular and pulmonary, integumentary and musculoskeletal, neuromuscular, communication, learning style, affect, and cognition. Systems review components. With the cardiovascular pulmonary system, we're going to look at blood pressure, heart rate, respiratory rate, and edema. With the integumentary system, we're going to look at pliability of the skin, the texture of the skin, presence of scar formation, skin color, and skin integrity. Hey. Yeah, let me pause this. Okay. So, integumentary. The pliability, the texture of the skin, presence of scar formation, skin color, and skin integrity. Musculoskeletal, during the systems review, we're going to look at gross range of motion, gross strength, gross symmetry, height, and weight. With the neuromuscular components, we're going to look at gross coordinated movements, watching them transfer and do transitional movements. And then we're also going to look at the motor function, their motor control, and their ability to motor learn. Let's see something. Ooh, that's interesting. I'll leave this down here. Okay. You may also include the affect, cognition, language, and learning style. The ability to make needs known, consciousness, expected emotional behavioral responses, learning preferences, needs and barriers, and orientation to person, place, and time. Now it won't move. I can want to go to slideshow. Oh, there we go. Okay. Based on the history, the review of systems, and the systems review, we have to determine, is PT appropriate? Is the referral needed? Who and when? Are further screening tests and measures needed, and who can do them? Pattern recognition, and then a hypothesis of a potential diagnosis. The following slides break down symptoms specific to the organs of the body to help you recognize patterns. Signs and symptoms of the body. The cardiac system, you're going to look for chest pain, irregular heartbeat, dyspnea, orthopnea, fainting, dizziness, rapid onset of fatigue, peripheral edema, cold hands and feet, decreased pulse, lower extremity claudication, cyanotic nail beds, and abnormal resting vitals. The pulmonary system, you're going to look at sharp, localized chest pain, fever and chills, aggravated by cold air or exertion, increased pain with recumbent position, decreased pain when lying on involved side, cough with or without blood, sputum, shortness of breath, crackles, wheezes, clubbing of nails, pain with deep inspiration, decreased oxygen saturation, weak rapid pulse with decreased blood pressure, and signs of a pulmonary embolism. With the hepatic system, we're going to look for right upper quadrant pain. Hepatic meaning the liver. Right upper quadrant pain, weight loss, lower extremity edema, carpal tunnel symptoms, intermittent pruritus, weakness and fatigue, dark urine clay-colored stools, hysterics, a tremor due to inability to maintain wrist extension with forearms supported, jaundice, bruising, Gallowing sclera of the eye, pain in T-spine between scapula, right shoulder and right upper trap, and right subscapular region, palmar erythema, white nails, not pink. If we're addressing the endocrine system, we're going to look for complaints of joint and muscle pain, paresthesia, dry scaly skin, constipation, fatigue, dyspnea, brittle nails and hair, cold intolerance, weight change, periorbital edema, hoarseness, polydyspnea, and polyuria. Signs and symptoms of something going on with the gastrointestinal. The symptoms are going to be influenced by eating. Epigastric pain with radiation to the back, blood or dark tarry stools, fecal incontinence, urgency, diarrhea or constipation, pain that changes with eating, nausea, vomiting, bloating. Food may help or aggravate the symptoms. Weight loss, loss of appetite, and rebound tenderness, Blumberg sign. Signs and symptoms of something going on with the renal system, the kidneys. A positive Murphy's, percussion over the kidney. Fever and chills. Dull, aching pain aggravated by prolonged sitting. Blood in the urine. Cloudy or foul-smelling urine. Painful or frequent urination. Pain is constant. Back pain at the level of the kidneys. Costovertebral angle tenderness. Skin hypersensitivity. Hypertension. And a bleeding tendency. And this shows the McBurney's point, which is 2/3 of the way from the umbilicus to the ASIS. The umbilicus to the ASIS. 2/3 of the way. And the rebound tenderness is called the Blumberg sign. And then for the kidney, you got the Murphy's percussion test. Signs and symptoms by organ. Prostate. Men over the age of 50 with complaints of back pain or suprapubic pain, difficulty starting or stopping urine flow, octuria, peeing in the night, incontinence, sexual dysfunction, and a PSA level greater than 4. Gynecological, cyclic pain, abnormal bleeding, nausea and vomiting, vaginal discharge, chronic constipation, low blood pressure, missed or irregular periods, pelvic pain with cough or intercourse. And this is a picture that kind of shows the area of pain. You can see here the diaphragm is up here. And then you have your osteophagus, esophagus, the heart, the stomach, the spleen. Spleen's one on the side of the, looks like the left side, right under the ribs. The gallbladder would be on the right side. The liver would be on the right side. Small intestine, colon, kidney, ureter, can't say that word, appendix, and bladder. Further system breakdown. Potential red flags, not alone. Symptoms out of proportion to injury. No change in symptoms despite position, rest, or treatment. Symptoms persist beyond expected healing time. Recent or current fever, chills, night sweats, infection. Unexplained weight loss, pallor, nausea, dizziness, vomiting. Headache and visual changes. Pigmentation change, nail changes. Rash, edema, history of cancer. No patterns or unreproducible symptoms. Night pain. Progressive neurology symptoms. Cyclic representation. Joint pain with skin lesions. Immediate medical attention. Resting systolic blood pressure greater than 180 or less than 90. Diastolic blood pressure greater than 110. Resting heart rate greater than 100. Resting respiration rate greater than 30 without known pulmonary disease or gradually worsening dyspnea. Sudden change in mentation. Facial pain with retractable headache. Sudden onset of angina or erythema. Abdominal rebound tenderness. Black, tarry, or bloody stools. Signs and symptoms of a TIA. Angina without relief or change in pattern of angina. Syncope. And symptoms of cauda equina. Diagnosis-specific differential screening for the physical therapist. We have the vertebral basilar artery insufficiency screening questions. You got your 5 Ds, you got your dizziness, your drop attacks, diplopia, dysarthria, dysphagia. And then 2 A's, ataxia, anxiety. Three M's: nausea, numbness, and nystagmus. What degree of rotation and side bending decreases blood flow from the vertebral artery? What other diagnosis could be causing the symptoms? What is risk of vertebral basilar artery dissection after manipulation? And here's your answers. Cervical rotation and side bending 20 degrees. So 20 degrees of rotation and side bending decreases blood flow from the vertebral artery. What other diagnosis could be causing the symptoms? Cervicogenic dizziness, vestibular, cardiac hypotension, MS for double vision, and GI nausea. What is risk of vertebral basilar artery dissection after manipulation? 1 to 1.3 million treatment sessions, or 400,000 manipulations. Cervical myopathy. Sensory disturbance of the hands, muscle wasting of the intrinsics, unsteady gait, Hoffman's reflex, clonus. So a positive Hoffman's reflex and a positive clonus. Is that the same thing? I'm thinking so. Hyperreflexia, bowel and bladder disturbances, multi-segmental weakness and or sensory changes. So here a review on the deep tendon reflexes should be graded on a scale of 1 to 0 as follows. 0, absence despite reinforcement. 1, present only with reinforcement. 2 is a normal. 3 is increased but normal. And 4 is markedly hyperactive with clonus. So with the deep tendon reflexes, a 2 is normal. Then the 1 is present only with reinforcement, and the 0 is absent despite reinforcement. A 3 is increased but normal, and then a 4 is markedly hyperactive with clonus. What other diagnosis would demonstrate a positive Hohmann's or clonus? What diagnosis would have hypotonia? Cervical instabilities, signs and symptoms. Occipital headache and numbness. Cervical muscle spasm. Drop attacks. Severe limitations in C-spine, active range of motion in all directions. Bilateral or quadrilateral paresthesia or motor deficits. Impaired sensation of the face. Altered taste. Acute anxiety and panic. Nausea and nystagmus. Oops. The Sharp-Purser test is one of the tests you do to check for cervical instabilities. It's a relocation of the dens to the atlas, and it tests the transverse ligament. The alar ligament test also tests for cervical instability, and it tests the alar ligament. So the sharp pursor test is the transverse ligament, and the alar ligament test, it tests the alar ligament. And there's a picture. Right here is the alar ligament right here. And the transverse ligament is right here. So the alar ligament stress test this one, and the transverse ligament test this one. Oops. So the sharp pursor test is a relocation of the dens to the atlas, and its purpose is to assess the integrity of the transverse ligament and the upper cervical spine instability. During the test, the patient assumes a sitting position. The patient's head should be slightly flexed. The examiner assesses resting symptoms. Do you feel dizzy or lightheaded? The examiner stands to the side of the patient and stabilizes the C2 spinous process using a pincer grip. Gently at first, the examiner applies a posterior translation force from the palm of the hand on the patient's forehead towards a posterior direction. Symptoms are assessed for both degree of linear displacement, palpated, or symptom provocation. Collectively, a positive test is identified either by reproduction of myelopathic symptoms during forward flexion or a decrease in symptoms during an anterior to posterior movement or excess displacement during the anterior posterior movement. Positive test. Reproduction of myelopathic symptoms during forward flexion or a decrease in symptoms during an anterior to posterior movement or excessive displacement during the anterior to posterior movement. And below you can see the sensitivity and specificity ratings here. This study here didn't test that. And this study here got a 69% sensitivity, which means that 69% of those who had the instability tested positive for the test. But it's higher in specificity, which means that 96% of the people who didn't have the condition tested negative for the condition. Yep. Got to get that down. Alar ligament test. Test the alar ligament. That's easy enough. The patient assumes a sitting or supine position. The head is slightly flexed to further engage the alar ligament. Okay? The examiner assesses the resting symptoms. Are you dizzy? Do you feel lightheaded? The examiner stabilizes the C2 spinous process using a pincer grip. A firm grip ensures appropriate assessment of movement. So make sure you know how to find that C2. Okay? Either side flexion or rotation is passively initiated by the examiner. Side flexion. So you got it, you're side flexing. During these passive movements, the examiner attempts to feel movement of the C2. So you got your pencil grip right on the C2, and either rotation or flexion, lateral flexion, side flexion, to feel movement of C2. A positive test is the failure to feel movement of the C2 process during side flexion and rotation. So if the alar ligament is unstable, then it's a stability test. So if you get a positive test, that means that it's stable or unstable. I don't know, I'm going to have to check that out. Viral or bacterial meningitis. With viral or bacterial meningitis, you're going to have neck pain and stiffness, headache, fever, vomiting, and nausea, photophobia, confusion, seizures, and sleepiness. Positive symptoms with dural tensioning test. The Brudzinski neck sign, the reflex flexion of the patient's hip and knees, are passive flexion of the neck. A Turgen sign is extension of knee on a flexed hip at 90 degrees, causes restriction and pain beyond 135 degrees. And I guess these two tests will determine if someone has viral or bacterial. Excuse me. Meningitis. Woo-hoo. Myocardial infarction. Oops. Typical. Fatigue times several days. Okay, we're resuming. The nurse came in. Where were we? Okay, let's go to non-typical, more common in women. Isolated, continuous mid or upper thoracic pain. Less chest pain than the typical. Anxiety or depression. Sleep cycle disturbance, some relief of indigestion with antacids, isolated right bicep ache. It feels like breathing cold air. Mental status changes in women, and heavy arms. So the heart attack pain diagram. This first picture you see localized just under the breastbone or in larger area of mid-chest or entire upper chest. Common combination of mid-chest, neck, and jaw. The neck and the mid-jaw and the mid-chest. Mid-chest and inside of arm. Left arm and shoulder more frequent than the right. Upper abdominal, where most often mistaken for indigestion. Ruling out myocardial infarction, the 3 P's. Pleuritic pain is worse with deep breathing. Pain on palpation. Pain with changes in posture. So I guess these 3 P's will help you rule out a myocardial infarction. Pleuritic pain, pain on palpation, and pain with changes in posture. Upper extremity DVT. The presence of venous material such as a catheter or access device in the subclavian or jugular vein or a pacemaker is a +1. So if you go down here to the bottom, you see 1 equals a moderate risk, 20% probability, and 1 or greater to 70% probability. So since this is a 1+, we're looking at probably a 20 to 70% probability of an upper extremity DVT if there's presence of venous material such as a catheter or access device in the subclavian or jugular vein or a pacemaker. Pitting edema in the upper extremity is a 1+ again, so that's a 20 to 70% probability. Localized pain in the upper limb, 1+. So again, 20 to 70% probability, but that's a pretty wide range of probability if you ask me. Another diagnosis, at least as plausible as DVT, is a -2. So that would be probably right around a 70% probability. I think I'm interpreting this screen correctly. Wells CPR for lower extremity DVT. And this little clip-in was very hard to read, but I'm going to do my best. So the symptom is active cancer, treatment ongoing or within previous 6 months, or palliative is a score of 1. So if you look down here at the bottom, a score of 1 to 2 points, is a moderate risk, 17%. So active cancer has a 17% risk for a lower extremity DVT. Then we're looking at paralysis, paresis, or recent plaster immobilization of the lower extremities. Again is a 1, 17%. Recently bedridden, more than 3 days, or major surgery within 4 weeks is a 1. So again, we're looking at 17% risk. Localized tenderness along the distribution of the deep vein venous system, a 1. Entire leg swollen, a 1. Calf swelling 3 centimeters, asymptomatic side. Measure 10 centimeters below the tibial tuberosity is a 1. Pitting edema confined to be symptomatic leg, a 1. Collateral superficial veins, non-varicose, a 1. Alternative diagnosis as likely or greater than that of a DVT is a 2. So all of these listed here is a 1, which would be a moderate risk, and actually a 2. So you have to be greater than a 2 or less than a 1 to be, none of these are, all of these are 17% risk. All of them. Okay. Pulmonary embolism symptoms. Oops. Unusually substernal, but can be chest, shoulder, or upper abdominal pain. Crushing chest pain. Dyspnea. Tachypnea. Tachypnea. Tachycardia. Wheezing. Decrease in blood pressure. High fever. Persistent cough, anxiety, and restlessness. So those are the risk factors. Stratifying risk, exam findings. So you see here if you have, tachy breathing, heavy breathing, or slow breathing, they're going to be at risk for pulmonary embolism. The sensitivity is 73, and the sensitivity here is 70. So sensitivity is the likelihood that someone who tests positive will have the problem. So if someone has slow breathing or fast breathing, they're pretty much both going to have the same risk of having a pulmonary embolism. Now, I don't remember what positive LR. I'm not real good with the likelihoods. I need to kind of brush up on that, I guess. Pulmonary embolism, variable. Clinical signs and symptoms of DVT. Let me move this. Wells score is a 3. So a 3 is moderate risk of a pulmonary embolism. An alternative diagnosis is less likely than a pulmonary embolism. Moderate risk. Heart rate greater than 100. 1.5. So a 3.6 probability. So because I'm tachycardia, I have according to this, to the Wells score, I have a 3.6 probability that I'm going to have a pulmonary embolism. Immobilization or surgery in the previous 4 weeks, 1.5. It's a low risk. 3.6 probability. A previous DVT or pulmonary embolism is a 1.5. Hemolysis is a 1, which is a rupture of red blood cells and release of contents in bloodstream. And a malignancy on treatment or treated in the last 6 months is a 1. So none of these factors are higher. The only one that's higher is clinical signs and symptoms of DVT. And alternative diagnosis is less likely than a PE is a 3. So that's in the moderate risk. Everything else is in the low risk. Yep. Cancer! Woohoo! Cancer. Risk factors. Previous history of cancer. Over the age of 50 years old. Additional concerns. Failure to improve with treatment over a month's time. Unexplained loss. Unrelenting night pain. Cancer pain at skeletal sites. Most common cancers to metastasize to the bone. Prostate, breast, kidney, thyroid, and lung. Metastasis to skeleton is common along with lung. Thoracic is 60%. Lumbosacral is 40%, but the cervical spine is rare. Other cancers that can refer pain to the cervical thoracic spine. Thyroid, esophageal, Hodgkin's lymphoma, Pancoast tumor, multiple myeloma, breast cancer, internal organ centers. So when you get cervical thoracic spine pain complainers, testing or screening for cancer is going to be a big deal. Thyroid, esophageal, lymphoma, Pancoast, myeloma, breast cancer, internal organ cancers. All can refer pain to the cervical thoracic spine. Wow. Good to know. Skin cancer screening. The ABCD of melanoma recognition. A, asymmetric or irregular shaped lesion. That definitely has an irregular shaped lesion. Borders, notches, scalloped, or vaguely defined. Yep. That sore right there meets that criteria. C, color, unevenly distributed or defined. That's different colors in different areas. And the diameter is less than 6 millimeters. Okay. Abdominal aortic aneurysm, AAA. Why don't we talk about this diagnosis? Well, 60 to 80% mortality. Reduced mortality with early detection. Rupture risk is greater with the larger size. Clinically relevant above 4 centimeters. May present as back pain, groin pain, or flank pain. It can radiate to the posterior thighs. You screen through risk factors and symptoms. Men greater than women. 60th to 90th decade. Family history. Obesity, smoking, hypertension, can't talk today. Atherosclerosis, high cholesterol, and emphysema. Initiation of weightlifting program. Symptoms: throbbing or pulsating, rapid and severe pain, can't get comfortable, tearing or ripping, clammy skin, nausea, vomiting, and rapid heart rate. Those are the symptoms. And there is a bigger picture of a normal aorta and an aorta with a large abdominal aneurysm. Cauda equina. Why do we talk about this diagnosis? Because it's a medical emergency. Call 911 quick. Refer either to a physician or local ER immediately. Greater success treating with surgery if treated within 48 hours of onset. Commonly occurs from disc prolapse. So what are the warning signs? Loss of feeling, pins and needles between your inner thighs and genitals. Numbness in and around your back passage or buttocks. Altered feeling when using toilet paper to wipe yourself. Increasing difficulty when you try to urinate. Increasing difficulty when you try to stop or control your flow of urine. Loss of sensation when you pass urine. Leaking urine or recent need to use pads. Not knowing when your bladder is full or empty. Inability to stop a bowel movement or leaking. Loss of sensation when you pass a bowel motion. Change in ability to achieve an erection or ejaculate. Loss of sensation in genitals during sexual intercourse. And there is a big picture of that. Ankylosing spondylitis. The symptoms are morning stiffness that lasts more than 30 minutes. Improvement with exercise and not rest. Night pain, second half of the night only. And alternating buttock pain. So morning stiffness that lasts more than 30 minutes An improvement with exercise, not with rest. Night pain, second half of the night only. And alternating butt pain. So 2 fourths are positive. So it looks the specificity is high in both of those studies, which the proportion of the patients without the disease who test negative, which means the test correctly identified 94% of those who does not have ankylosing spondylitis. So 95% tested correctly, negative. More males, so males more than females, 17 to 45 years old, begins as low back or sacral pain, may also have pain in shoulders. Bamboo spine with ossification is seen later in stages. Fracture considerations. Cervical fracture C-spine rules. The Canadian C-spine rule. 1. Any high-risk factor which mandates radiography. Age 65 or older, or a danger mechanism or paresthesia in extremities. Yes. So if someone is 65 or older, dangerous mechanism, has paresthesia in the lower extremities, then if they have that, any of those three, they are a high-risk factor which mandates radiography. So yes, to the x-ray you go. If they don't have any of those three, any low-risk factor which allows safe assessment of range of motion. Okay. If they've had a simple rear-end motor vehicle accident, if a sitting position in the emergency department, ambulatory at any time, delayed onset of neck pain, absence of midline C-spine tenderness. So if it was just a simple rear end motor vehicle accident, that would be yes. Yes, it was a simple rear-ended motor vehicle accident. Yes, I was sitting in a sitting position in the emergency department. Yes, I was walking in to the emergency department. Delayed onset of pain. Absence of midline C-spine tenderness. If any of those say yes, there's no tenderness in my spine, then they go down to 3. If they say no, like, no, it wasn't a simple rear-ended motor vehicle accident. No, I was not sitting. I was lying down in the emergency department. No, I was not walking. I do have midline C-spine tenderness. Then straight to radiography you go. That's just how it is. So, if you say yes to those, then you go down to 3. Able to actively rotate the neck. Can you actively rotate the neck 45 degrees to the left and 45 degrees to the right. You can do that. No radiography, no x-ray. If you're unable to do that, then you go have x-rays. So these three little dots right here, when it says delayed onset of neck pain, not immediate onset of neck pain. It's not immediate. Not you're having current neck pain. Do you have current neck pain? Delayed onset. If you have current neck pain, then you go to radiology. If it's delayed onset, then you go down to number 3. It's not immediate neck pain. Okay. Can you move your neck to the side? Yes. No x-ray. Just how it is. And a dangerous mechanism where they talked about up here, dangerous mechanism in 1, that would be a fall from an elevation of more than 3 feet, 5 stairs, an axial load to the head, diving, motor vehicle accident, high speed, greater than 100 miles per hour, rollover or ejection, motorized recreational vehicles, and a bicycle collision. The little 2 dots up here, simple rear-ended motor vehicle accident, would be motor, I don't know, MVC, I'm not sure what that means. What does that mean? Anyway, pushed into oncoming traffic, hit by bus or a large truck, a rollover, or hit by high-speed vehicle. Wow. So if you said yes, you still go down here. Pushed into oncoming traffic, hit by a bus. Okay. Okay, Canadian C-spine rules. Critical actions here. If a patient has any high-risk factors, age greater than 65, a defined dangerous mechanism, or paresthesia in the arms and legs, then they require C-spine imaging. I got interrupted again. That's okay. So, if a patient has any high-risk factors, age greater than 25, a defined dangerous mechanism, or paresthesia in the arms or legs, then they require C-spine imaging. If the patient has no risk factors, but meets one of and meets none, I gotta ask about that in class. Meets none? No, okay, I get it now. Meets none of the defined low-risk criteria, they require C-spine imaging. If the patient has no risk factors, has neck pain, but meets even one low-risk factor, then it is safe to assess whether the patient is able to rotate their neck 45 degrees to the right or 45 degrees to the left. If they can do this, even with some pain or discomfort, then they do not require further imaging. If they cannot rotate their neck 45 degrees in both directions, then C-spine images are indicated. So, this sensitivity and specificity range is very wide. Look at that. That's very wide. Well, this is 90 to 1. So it looks like the sensitivity is better than the specificity. Interesting. The Ottawa ankle rules. Bony tenderness along the distal 6 centimeters of the posterior edge of the fibula or the tip of the lateral malleolus. Bony tenderness along distal 6 centimeters of the posterior edge of the fibula or lateral tip of the lateral malleolus. So we're looking right here. Posterior edge or tip of lateral malleolus. The 6 centimeters, right in there. Right in this part, right here. Bony tenderness along distal 6 centimeters of the posterior edge of the tibia and tip of the medial malleolus, which is going to be right here. So these two darkened spaces right here, medial and lateral. Bony tenderness at the base of the 5th metatarsal, which is going to be right here, the 5th metatarsal. Bony tenderness at the navicular, which is medially, is right here. Inability to bear weight both immediately after injury and for 4 steps during initial evaluation. So inability to bear weight both immediately after injury and for 4 steps during the initial evaluation. Looks like I covered it up. If none of the above are positive, then know something. I covered it up with this. Anyway, the sensitivity is 98%, which is very high. So these Ottawa ankle rules, you follow these rules, and they're positive, then it's a positive test. Then know something. Let me get on there, see if I can fix that real quick. See what that says. Ooh, okay. Then no imaging is required. Let me fix that real quick. There we go. Move that back up there. Go back to slideshow. Okay. So if none of the above are positive, then no imaging is required. But how many of these do you have to have a 98% sensitivity percentage? 1. So I guess if you have any of these, 1, 2, 3, 4, 5, any of these symptoms, then imaging is required. Interesting. Alrighty then. Ottawa knee rules. Okay, so there was no way for me to make this look better because it was a cut and paste on the instructor's side. Ottawa knee rules. Well, I could have made that one look better. Knee x-ray indications. Ottawa knee rules. Age greater than 55 degrees. Isolated patella tenderness. Tenderness at the head of the fibula. Inability to flex the knee 90 degrees. Inability to bear weight 4 steps immediately after injury or in the emergency department. And it has a sensitivity of 85 to 100%. So that sensitivity rate is pretty high. And that's the ankle again. Okay. Osteoporosis, risk for insufficiency fracture pathologic. Osteoporosis risk assessment instrument in females. So age predictor. So I'm 49, so I would be in the D, and my score would be 0. So what does that mean? If less than or equal to 8, then no bone densitometry indicated. Weight in kilograms. Well, weight in kilograms. I'm greater than 70, so I would be a 0. Okay. And use estrogen. No. So I would be a 2. So what other diagnosis have a risk for pathological fracture? So that would be a great question for our teacher when she goes over this lecture. Joint pain. Osteoarthritis. So this looks like it's comparing and contrasting osteoarthritis, rheumatoid arthritis, and gout. Osteoarthritis is asymmetrical versus rheumatoid arthritis is symmetrical with edema. So with your osteoarthritis, it's going to be asymmetrical. And with your rheumatoid arthritis, it's going to be symmetrical with edema. Those with osteoarthritis, large weight-bearing joints will be affected, like hips and knees. With rheumatoid arthritis, the small joints of the hands, feet, and wrists. With osteo, loss of joint surface integrity. Osteophytes, decreased range of motion. Stiffness, less than 1 hour. Deep ache. And I think the stiffness less than 1 hour, I think they're relating that to upon awakening. So finishing up rheumatoid arthritis, you'll have erythema, redness and fever, intense pain after rest, weight loss, weakness, and loss of stamina. It's more in women than men. Other systems affected is the lymphadenopathy, enlarged spleen, and vasculitis. And they have greater than an hour stiffness. Deformity and subluxations in rheumatoid nodules. So over to the third category, which is gout. It affects only a few joints. First, the MTP, metatarsal phalangeal, the knee and the wrist. Abrupt onset, uric acid crystals, increased frequency with age. It's greater in males than females and usually begins at night. Neuropsychiatric disorders. Depression may be accompanied by anxiety, sadness, frequent and unexplained crying, feelings of, I should probably say guilt instead of guild. Feelings of guilt, hopelessness, or helplessness. Suicide ideations, problems sleeping, fatigue or decreased energy, apathy, loss of appetite, weight loss, gain. Difficulty concentrating, remembering, and making decisions. Panic disorders. Tachycardia, chest pain, dizziness, nausea, difficulty breathing, bilateral numbness, face tingling, sweats or chills, sense of terror, extreme fear of losing control, fear of dying, feeling of choking, vertigo. Unhelpful tool for screening manic depressive disorder is a mood disorder questionnaire. Let's see. Non-organic signs and symptoms. Positive Waddell signs. Potential indicator of central sensitization indicated a likelihood of having functional limitations and an impaired quality of life, particularly in young women. Debated as a predictor of illness behavior or psychological distress. Must consider the total clinical picture of the patient. It's like another article. The presence of Waddell signs depends on age and gender, not diagnosis. Includes tenderness, stimulation, distraction, reasonable overreaction. And this slide, I don't really understand, so maybe her lecture will help on that. The 5 categories and 8 non-organic signs of the Waddell score. Okay, here we go. Tenderness, stimulation, distraction, regional disturbance, and overreaction. Non-organic tests: superficial, non-anatomical, axial loading, rotation, distraction, weakness, sensory, overreaction. Non-organic signs: widespread tenderness to light pinches over a wide area of lumbar skin. Deep tenderness felt over a wide area, not localized to one structure, and often extended to the thoracic spine, sacrum, or pelvis. Low back pain reported when light pressure is applied to the patient's head while standing. Low back pain reported when the shoulders and pelvis are passively rotated in the same plane when the patient is standing with the feet together. Inconsistent limitation of straight leg raising in supine and seated positions. Partial cogwheel giving away in many muscle groups. Sensory disturbances include diminished sensation to light touch, pinprick, and sometimes other modalities fitting a stocking rather than a dermatonal pattern. Disproportionate rubberization, facial expression, muscle tension, and tremor, collapsing or sweating during examination. The following slides review of differential pathologies by location. All tables are from Dutton, as I expect you will want to visit a larger copy. These are good objective resources to help you complete your medical intake assignment. Differential diagnosis considerations by location. And as you can see, I just blew up that big chart in the previous slide. I just went ahead and blew it up. So I'm going to take a pause and eat my dinner and get back to this in a few.